Yeah, it seems a little bit an open door, but it isn't. Compared to all the evidence that there is available, normally the last evidence is the most important evidence. And here's the opposite. The old evidence is everything where we rely on, and it's, I think, important to stress why. In the disclosures, in the old days, so that's quite long ago, even before 2000, there were worldwide 180 EBT systems at the maximum. Most of them were in the US, and there were only 1 or 2 systems in Europe, and in Asia there were also 10 or 20. And the advantage of the EBT system is that it's a non-mechanical system. It's the most standardized CT system that there is. It's ultra-fast, specially designed for measuring the heart. And it was capable of measuring the calcium score in a manner that has not been replicated anymore afterwards. So the old evidence, therefore, is the best quantified, standardized measurement of coronary calcium that we had ever up till now. So what we have to do is everything that we develop with the new systems, the mechanical systems, compare it to the outcomes of EBT to get reliable calcium scores. And what is happening at the moment, especially in calcium scoring in lung cancer screening, they just use the scores as absolute truth. So it's a number, and they just rely on the number that it is right and gives you the same stratification as where the old literature pointed out to. So the evidence that, and I will show what evidence is, there is not that much evidence, but there are very large studies, and they are quite important because it's the only evidence we have so far. And there is also some evidence that is related to smoking, so I would like to go stepwise through this evidence that is available. So one of the first studies was from my team in Rotterdam in that time, in 2,000 asymptomatic participants. So they were not chosen for smoking or that kind of stuff, but they were just followed up as a study, population study, how people age in the region of Oudkerk in Rotterdam. And in those 2,000 asymptomatic participants, we found 135 heart coronary events. And from this, we had the first, and that is very important, the first indication that you could re-stratify the population compared to the conventional risk scores. And that is still, I think, the first and most important thing, that the stratification that you can do with calcium scores is far better than you can do with all traditional risk scores that are at the moment. And we could prove that we could re-stratify with heart outcomes in terms of heart coronary events, more than 50% of the population compared to the Framingham score. So that was really impressive. And then also a very old study. This is our own study, so you see it per class. So for risk scores low, we had 12% reclassification, and the intermediate, more than what I already said, more than 50%, and even also the high scores. So that is, I think, one of the very important first steps towards new risk stratification that can be done with calcium scores. Then another study, also that was more recent, 2016, and it had a very long 15 years follow-up, and it was in a very large cohort, and this cohort had almost 10,000 asymptomatic individuals, and they were active smokers, but not stratified in the way that we do it in lung cancer screening. So they were just active smokers, and that's the way they presented with the general practitioner. And those were patients with dyslipidemia, diabetes, hypertension, and a family history of early coronary artery disease. Now, the image acquisition has been done in this whole population of almost 10,000 people with EBT, and the study follow-up, I said, was almost 15 years. So those are very interesting figures, and here they found the same, in fact, that the risk stratification done by coronary calcium outperformed all the other risk factors together. And here you see what, per age category, what the risk increase is compared to a zero score. So that goes up from 2 for the scores till 400, up to 10 times higher for a risk over the 1,000 calcium agonist score. So those are very, I think, important figures to realize what can be done. And then there is in the same study also some information on the, and I think that's quite interesting, on the smoking status and the smoking risk in this population. So this is a different population than only active smokers. But here you can see, and I think that's very nice, that the coronary calcium score outperforms even the smoking risk if you are older than 60 years old in this population. So that is, if you see, if you have a look here, so down here it's lower than 2, even almost not higher than the risk of being 70 years old, so compared to the age. While if you go to the calcium score, it's up to 4 and 3. So that means, and that has real impact in our thinking about what we are going to do with a calcium score in a lung cancer screening setting, that a calcium score could be even more important in the older ages, and that is where we do lung cancer screening as a mortality risk predictor if we do not really stratify the smoking status in a way that we have a higher mortality expectation in the pre-test situation. So I think this is very amazing data. Now, recently then in 2018, there has been a very important overview of Greenland, and that triggered more or less also the American Heart Association guidelines, and he came up with 4 studies. So the Rotterdam study, which I showed, then the Hein-Nixdorf study, the MESA study, which is, I think, the largest and very important study in terms of multi-ethnicity, and then the Framingham study itself. And they all concluded that the 3 studies showed a better risk prediction compared to conventional risk scores. So I think this should be one of the most important messages, that still in normal clinical practice, the clinical conventional risk scores are used all the time without the calcium score, and the calcium score is probably far better to use than any conventional risk score. Then we go to this, also I think a very nice and important study. It's an early study. It's also a very large study in 44,000 people. And this was not a real prospective study, but it was an observational study. But it showed, and there is not many evidence smokers compared to non-smokers, but it showed, and I think that is very interesting, that a zero score is a very important predictor in all disease categories for final outcome. Even if you have diabetes, for example, a zero score will predict almost the same survival rate as in a normal person. So the zero score could have indeed an enormous impact on lowering down overtreatment and overdiagnosis. And here, if we zoom in that cohort, we have 2,000 individuals with a calcium score of 0 and an almost 6-year survival. and 6,000 of them were active smokers. Not really stratified again, as we do it, but active smokers in self-reporting to the GP. And then you can see that the survival in smokers and non-smokers is almost comparable. So that means the zero score could have indeed an extremely important impact on decision-making in the daily care. But then the question arises, so from all this evidence, we said already, so the radiologist from the United States and from Europe, we said the zero score should be implemented in 2008. But then it took 10 years before the American Heart Association came to the same conclusion. And they more or less said this without referring to our own guideline papers. And then the calcium score, that's why I say it is reasonable to withhold statin therapy and reassess in 5 to 10 years. So that is very important also for what we are doing and what we are reporting. But then zero should be zero. And that is what I said in the beginning, only reliable with the EBT systems. And here you can see the whole development after the EBT. So we have this MESA study, which was done with the EBT. Then also the framing, the Rotterdam study has been done with the EBT. And then we developed all kinds, and there were many studies to translate the EBT data to modern systems. And we did a very large study in 40,000 people, the Robinska study, which still has to publish its final outcome. And that is prospectively triggered, so not gated, but prospectively triggered. I cannot go in all those details what is a better method. But the best method and everything that has been published on the EBT data have been prospectively triggered. So not a selection of data afterwards, after the data acquisition, but a targeted measurement at a moment that is optimal in the time of the diastole of the heart. So up till now, there is very poor evidence about the reliability of the zero score in CT systems that are non-EBT systems. So what has been already shown in former presentations, especially in young people you can have cardiac events without any calcium. So this is a very nice example of a different technology. One is a 3 millimeter reconstruction with a zero score, and then with a thinner slice reconstruction, you find the calcium. And that is, so there are many, it's not only the data acquisition, it's also the post-processing, which is important to come to a real, reliable zero score. Now here you have a comparison between gated versus non-gated. And then you can also see that here you get up to 40% reclassification if you gate versus non-gating. And that is even not in the best optimal way of analyzing your data. Now we did our own study also in many cases in a comparison to different methods before we implemented our data acquisition scheme in foreign neuron. And so we had also a direct comparison between non-triggered third generation CT, so that's the fourth system, which we implemented in foreign neuron, compared to a second generation cardiac CT acquisition, which we delivered in Robinska study. And we compared those, and here you can see that you have indeed, reclassification still of 6%. So that is very important also in zero. Is this acceptable or is it not acceptable? That is the question. And we have a false negative rate of 2%. Is it acceptable or not acceptable? So those are the discussions that we would have, an almost 1% false positive rate. So we conclude here that for a third generation dual source CT system, we said it is acceptable, especially on very low doses, and that is, you can go up to 73%. And if you accept the reclassification of 6% compared to the optimal data acquisition, that is the best we can do in lung cancer screening. So progression can be established from 3.4%, that is what we showed before, and you can go lower than 1 millisievert in a combined protocol for lung cancer screening and for cardiac data acquisition. So we do one acquisition scheme of less than 1 second, and then we have 3 or 4 data reconstructions for the different applications, especially, of course, for the heart. And that is what we standardized, especially for the foreign learner study. But if this is really the best you can do, we don't know. So the best you can do is trigger everything, but it's not implementable, of course, in lung cancer screening. So with this, all those restrictions, we found at baseline for in the long run, so those are more than 11,000 participants, we found a zero score in females of 20% and males of almost 9%, and overall in 13.6% of participants, but a low one, so up to 100 in 37%, 27%, and overall in 31%. And so if this would mean that you could withhold statins in those categories, it has a very high impact. But also, even if you only use the zero score for decision making in treatment, especially in statin treatment, then it really has a very high impact. So overall, 55% of the foreign learner baseline cohort are eligible for statin therapy, and that is for smokers, I think, because those are all smokers and with a very high smoking profile. So it's very interesting that you have those participants that have a zero score. And that is, I think, but zero should be zero. And that is very important to realize where you are working with in your data. Now, then a very positive message for the ladies. They age, so if you take the words of the cardiologist seriously, then your age is the same as the true age is your coronary age. And women age 10 years later than men. So that is, I think, very hopeful for the women. They survive us. Then the other thing that is important related to smoking is, and that is this study, also I think quite interesting, quite recent. And they formed in the US from a coronary artery calcium consortium, in which they have in a total cohort that they brought together from a population that just physician-ordered calcium scores controls without known cardiac disease. So it's a kind of selection procedure to come to this cohort. And they have that cohort of 55,000 participants. So that's extremely high number. And this showed that the higher calcium scores were associated with increased risk for lung cancer mortality. So that, I think, is also quite interesting, that there is a relationship between the calcium score and the probability of dying from lung cancer. And I think that this association should be further studied, what the impact is of this relationship. If it could indeed further stratify those participants that should have closer screening protocols. So if you look in the same cohort, so the whole cohort of this group is 60,000 participants, so that's a very large cohort. And you can see here the mortality rates in this cohort, especially in those that are current smokers, and that are in this cohort 5,000 participants. And altogether, the relationship, and that has been shown also yesterday, between the mortality rates on cardiovascular, cardio heart, and the cancers, including lung cancers, there the mortality of the cardiovascular and cardio heart disease exceed the in smokers, the mortality of lung cancer. So that has also a very high impact how we approach in further thinking about how we screen optimal and who we should screen, and what the impact is if we have this information also from the calcium score, what that would work out in daily clinical practice. So the key points I would summarize here is that high-quality ECG-triggered acquisition EBCT data are available in only 3 population studies, of which 2 in a general population and only 1 in an active smoker population. So the data that are available for us are scarce. Then here, EBT data shown a 52 reclassification rate compared to the Framingham score. So an important message is, I think, the conventional risk scores could be bypassed by calcium scores and not vice versa. Then the EBT calcium score outperforms smoking status risk scores for persons over the 60 years. So that is, just in active smoking, so non-smoking stratified cohorts. All calcium score studies showed a better risk prediction compared to conventional risk factors, as I said before. The EBT calcium score study proved a comparable more than 5-year survival at 0 scores between smokers and non-smokers. And I think that's, still open for further debate. Translation of the high-quality EBT data acquisition to regular CT data acquisition mandatory, and especially for the 0 score. So when you have a 0 score on your CT scan, on a regular CT scan, mostly it will not be 0. And so you have false positive and false negative rates both. So you have to bring this forward probably if you have high suspicion to a real standardized method to measure the calcium score. So both false and false negative scores are very irregular there. And one of the very important things for the future to study is that the CT0 score has the potential to stratify lung cancer screening follow-up. So probably the 0 scores, you can stretch the interval of screening by 1, 2, perhaps 3 years. So that will be also, I think, a very important implication in terms of cost effectiveness, up to 50% more effective lung cancer screening. But that demands indeed that the 0 score is reliable. Thank you for your attention.